Hi, my name's Demi. I'll be the student nurse that's working with you today. Can you tell me your name and date of birth?
Jacob Shesso, 7798.
Okay, good. Alright, so I'm just coming in to do a quick cardiac assessment, listen to your heart, take a look if anything is abnormal, and ask you a few questions.
Okay.
Do you have any history of high blood pressure, heart failure, stroke, any AFib, heart surgeries,
No.
anything like that? Does your family have any history of that?
No.
Okay. Do you have any sleep apnea, any excessive sweating, excessive weight gain,
No.
shortness of breath when doing everyday tasks? Do you have to have any pillows behind you to help you breathe better at night?
No.
Do you have any swelling of your legs or your ankles?
No.
Okay, good. So I'm going to ask you a few questions. What do you do for work?
I work in a factory.
Okay, and what do you usually, what is a typical meal for you?
Grilled chickens and vegetables.
Okay. Do you exercise at all?
Yes.
And what do you do when you're exercising?
I run
How often do you do that?
once a day.
How many days of the week?
About 7.
And how many minutes do you usually run for?
About 30 minutes.
Okay, that's good. Do you drink alcohol at all?
No.
Do you use nicotine or tobacco?
No.
Good. Have you had any recent weight loss or weight gain?
No.
Okay. Do you take any medications on a daily basis? Anything like aspirin, water pills, blood pressure pills, or cholesterol pills?
No.
Good. So I'm going to go ahead and I'm going to take a look at your chest and make sure everything's looking okay. And then I'm going to palpate, feeling it just a little bit, and then I'm going to listen.
Alright.
Okay. So I'm finding my angle of Louis, and I'm going to my second intercostal on my right. So this is my aortic valve, and this is where the base of the heart would be. And then going to my left side, my second intercostal, this is my pulmonic valve. So this is where we hear the S2 or the dub. This is where the aortic and pulmonic valves are closing and the beginning of diastole. Then we have our Erb's point in our third intercostal space. Then we have our tricuspid valve. And then we go mid-clavicular and fifth intercostal. So right in here would be our mitral valve. So right here is where we hear S1 or the lub of the lub dub. And this is where we listen for the apical pulse. This is where the tricuspid and mitral valve is closing. So we have the beginning of systole. This is also the apex of the heart, and this is also the PMI, which is the point of maximal impulse, and this is where we can listen and the apical pulse will sound the loudest. We also can have some things known as S3 and S4. S3 would be a gallop, and this would be normal in young people and children who are athletic, things like that. And we start to worry that it's abnormal when it's in people who are a little bit older, because it can signal heart failure. And then we can have S4, which is when we hear a sound before S1, because S2 follows, or S3 follows S2, so S4 would be right before S1. And this signifies that there could be some uncontrolled hypertension, things like stenosis, and things like hypertrophy. Another thing we worry about for hypertrophy would be lifts and heaves, so we could feel the heart kind of moving, which again would be abnormal. We could feel something called a thrill, which would be like a vibration, which is caused by a murmur, and that's a turbulent blood flow. So again, that would also be abnormal. So I'm going to going to go ahead and listen. So I'm going to start off using my diaphragm, and I'm just going to start at your aortic and work my way down to your mitral. Okay, good. And since I'm here, I'm going to go ahead and have you lean forward and exhale for me. Okay, good. You can lean back. So right there, I was assessing for pericardial rub. That's a friction rub. It kind of sounds like two balloons rubbing together, and that can signify some inflammation, some infection, or some fluid buildup. So that would be another abnormal sound we would hear. I'm also going to listen to your apical and compare it to your radial pulse and see if we have a pulse deficit. Okay, good. There was no pulse deficit, so we're not worried about a decreased cardiac output at all. For this, we would usually listen to the apical for 1 full minute, maybe have another nurse step in and kind of help out by listening, but for practice reasons, I just did it myself and did it quick. So I'm going to go ahead and work my way back up from the mitral valve to the aortic valve, listening with my bell instead of my diaphragm so I could hear sounds like S3 and S4. Okay. Another thing we would be listening for would be stenosis, which would be the valve isn't fully opening, so it's very narrow and the blood can't get through. And then we could also be listening for regurgitation, which would mean that the valve isn't closing all the way, so that the blood is flowing backwards, which would be abnormal as well. So I'm going to go ahead and feel my patient's arms. They're nice and warm, dry. I can see that they're pink. And his capillary refill is less than 3 seconds, so that's normal. If my patient had some circulatory problems, we could see some cooler, clammy skin, maybe a little bit blue or cyanotic. If my patient had some venous issues, we could see red, purple, brown color discoloration to the legs. They would be swollen, so we would see some edema. And for this, we could have our patient elevate their legs, wear TED hose, and that could help with that issue. And for arterial insufficiency, we would see thin skin. It could be shiny with some hair loss, and our patient would have intermittent claudication. So this means that they would have pain when they're walking, and that's not good. I also want to talk about orthostatic hypotension. So for this, I would have my patient lay down for 5 minutes, and then after 5 minutes, I would take his blood pressure and his pulse. Then I would have him stand up, and then after 1 minute, I would take his blood pressure and his pulse again. Then after 2 minutes, I would take his blood pressure. And so my last video cut out where I was talking about orthostatic hypotension, but we would see a decrease in systolic by 20, a decrease in diastolic by 10, and then an increase in pulse by 20 beats per minute. And then with this orthostatic hypotension, we want to be careful because our patient could have falls. Also, I realized I forgot to talk about murmurs and thrills. So murmurs are rated on a scale of 1 to 6, 1 being quiet and 6 being very, very loud. Murmurs are turbulent flows of blood, so you can hear the turbulent flow, and then thrills would be when you can feel the vibration because of the turbulent blood flow.